The information in this podcast is provided for informational purposes only. You should not use any information discussed in this podcast and related materials to make medical or healthcare related decisions. Always consult your physician or other qualified healthcare provider with regards to diagnosing and managing your medical condition. Any medications or treatments, including any discussed in this podcast, should be initiated and managed by a qualified healthcare professional. Welcome to Long COVID The Answers. Today's episode is entitled Myalgic Encephalomyelitis or Chronic Fatigue Syndrome, otherwise known as MECFS, and Long COVID. I'd like to introduce Professor Ric Arseneau. Professor Arseneau is a clinical professor at the University of British Columbia in Vancouver, Canada, and a specialist in internal medicine with expertise in MECFS, fibromyalgia, and long COVID. He was the physician lead for the Provincial Echo Education Programme for Long COVID in BC and was formerly the Director of Programme Planning of the BC Women's Hospital Complex Chronic Diseases Programme in Vancouver. Welcome, Ric.
Thank you.
Ric, do you have any conflicts of interest to declare?
None, thank you.
Ric, could you please tell us how you became interested in chronic complex diseases such as MECFS, fibromyalgia, and long COVID?
So I just see it as an extension of my work as an internist. I've always liked complex multi-system diseases. And over time, I became the go-to guy in our division for anything that was unexplained, weird, wonderful. And so a lot of patients got referred to me, and I learned a lot from my patients. And over time, just through pattern of referral, got an interest and expertise in the area.
What is MECFS?
So MECFS is a complex chronic multi-system disease of unknown etiology. We do know that certain people are more prone to get it, like patients who have a family history of ME, fibromyalgia, or related disorders, patients who've had adverse childhood experiences, and genetics. But usually what happens is even in identical twins, only 50% of patients will both get ME. So there's definitely something in the environment that triggers it. And that trigger is usually some sort of overwhelming stressor. And the three main categories are infectious stressor, which is why we see post-viral ME. And then we see it also as a result of physical injuries like car accidents, but also as a result of psychological overwhelm because it is in the same family as PTSD.
Could you describe some of the symptoms and signs of MECFS?
So there are over 200 symptoms that have been described in ME, which can make it very confusing to physicians and to patients. But if you look at the forest rather than the trees, those symptoms fall into five major categories. There's fatigue with post-exertional malaise. There's pain, sleep disturbance, cognitive symptoms, or what patients call brain fog, and then weird and wonderful unexplained symptoms. And those include mostly brain symptoms, autonomic dysfunction, and gut symptoms, although there's a whole host of them. So basically fatigue, pain, sleep disturbance, brain fog, and unexplained symptoms.
The deep phenotyping of post-infectious MECFS study released online this month in Nature Communications seems to imply that prolonged infection from, say, a bacteria or virus alters our immune system and gut microbiome.
Yes.
In MECFS sufferers, they kind of said this leads to a chemical alteration in the brain and nervous system, so that part of the brain that controls motor actions fails to function adequately, leading to fatigue and post-exertional malaise. Do you agree with their findings?
Yeah, that's basically the main theories right now, is that some sort of overwhelming stressor like an infection causes brain-based changes. And they're usually identified at the level of the glial cells. And the glial cells, what happens is that they become activated. And so when I talk to patients, I say the glee is gone out of the glial cells and they're unhappy. And so that they produce inflammatory cytokines. And what happens is patients are stuck in a pattern where that cycle of activation can't be turned off. Because normally what would happen is with a stressor, you'd have an activation, you'd have resolution of the stressor, and then you'd have the body go back to baseline. What happens with MECFS, long COVID, fibromyalgia, is a switch gets stuck in the on position. And so that you can't turn off this cycle of glial activation, which leads to activation of the fight or flight system and dysautonomia, immune changes, inflammatory changes, and a whole bunch of changes downhill from the brain-based changes. Our best understanding right now is that it's a neuroinflammatory condition.
Okay, and so how do patients present to you? How do people present to you with this syndrome? I mean, practically speaking, is there classification or grouping of people that present?
They don't usually present to me because I do secondary and tertiary care. And unfortunately, the trajectory for many of these patients is a bunch of symptoms within that 200 range, which overwhelms their physicians, which leads to medical gaslighting or overwhelming amount of investigation with no resolution of the problem. I've had some patients see as many as 27 different specialists in this province without getting an answer. Luckily, with education, that has changed over the last couple of decades, and patients are being routed to the right care much earlier on. But patients usually present with fatigue, sleep disturbance, brain fog, pain, and unexplained symptoms. But depending on how they choose to focus on those symptoms, because our system is really not set up to help patients with multi-system diseases. Most patients are only allowed to present with 1 to 3 symptoms to their primary care physicians. Most of my patients have 20 to 40 symptoms. And then when they get sent to a specialist, the specialist is not interested in anything except the lens through which they want to see neurologic disease, cardiac disease, respiratory disease. And so patients are often left very unsatisfied, despite the fact that they do access a lot of medical care.
So what at the moment is the average timescale for someone suffering with chronic complex disease to be diagnosed?
I don't know right now, but so the last data that we have is from 2015, and the average at that time was 5 years. There's a paper that came out recently on POTS, postural orthostatic tachycardia syndrome, and that also showed 5 years. It also showed that over 90% of those patients received a psychiatric diagnosis before they got the correct diagnosis. And this was a study of Canadian and American cardiologists.
So personally, as a family physician or GP myself, I don't feel confident in diagnosing MECFS or fibromyalgia. And until I started to do lots of research, was at loss at managing these types of people. And I know my colleagues feel the same. What would be your advice with regards to a family physician approach to managing and diagnosing these patients?
I think there's a couple of rules of thumbs that serve you well. So when I teach my residents, I often ask them, I say, what's your one question that you want to ask a fibromyalgia patient, or one question that you want to ask a chronic fatigue patient that rules it out? So the one question that rules out fibromyalgia is widespread pain. If you don't have widespread pain, you don't have fibromyalgia, so you go down a different route. If you have fatigue but no post-exertional malaise, and so post-exertional malaise, patients will describe that as a crash. As soon as they do too much, even by just a bit, they crash, and it takes them a day, 2 days, 3 days, a week to recover. So without post-exertional malaise, there's no chronic fatigue syndrome, and without widespread pain, there's no fibromyalgia. So that's your entry point. After that, it's the 5 categories. You listen for fatigue, pain, sleep disturbance, brain fog, and unexplained symptoms, especially autonomic, GI, and neurologic. And that'll get you really far. If you go to my website, which you can see my name here on the screen, Dr. Ric Arseneau, that's the website, drricarseneau.ca, without the spaces and the dot. Under resources, I have put together a primary care toolkit for family doctors, and it gives advice on long COVID, chronic fatigue syndrome, fibromyalgia. There's also 2 videos. I participated in the long COVID Echo for New Mexico, and I did primary care toolkit for them. It's also the same toolkit I use for the CME at St. Paul's Hospital. So that's all available for family doctors. And then I think that for the most part, it's education. And so if you look at our website, you'll see that we have a YouTube channel. I invite special lecturers to come and talk about various topics. 50% of the topics are with occupational therapy and physiotherapy. And then the other 50% are on a range of topics, including, for instance, we just had pelvic pain syndromes, female hormones and pain, a naturopath approach to pain, dietitian and irritable bowel syndrome, dietitian and low inflammatory diet, mast cell activation syndrome, POTS, physiotherapy approach to POTS. So we have a whole bunch of education material, and that's why patients who are referred to our clinic can participate in all of our education's offerings even before they get to see the physician, so that we're not the bottleneck for them participating in getting care.
Okay, that's great. We will provide links from any research papers we mentioned in the program and also your website, both on the website and in the podcast channels where the podcast will be broadcast. So with regards to the educational videos, they sound really interesting. They sound like something that we as family physicians and the general public could benefit from. Are they accessible to us as well?
Absolutely. Yeah, so the one that I usually recommend as a baseline that explains these conditions overall is called Family and Friends, and it's had close to 10,000 views already.
Right, that's excellent. And so you've given the family physician approach. Listening to you, I would imagine it's incredibly frustrating as a sufferer to wait 5 years for a diagnosis in pain and distress. How do you advise them to approach maybe speeding up their own diagnosis and access to care? What approach should they take to prepare us ignorant physicians?
Well, usually what I recommend is self-education. And the patients can actually download the tools from our website to make a diagnosis themselves, fill out the form, bring it to their family doctor, and show that they fulfill criteria according to the 2003 Canadian Clinical Case Definition for ME, or they fulfill the 2016 definition criteria for FM, and bring that to their family doctor. Other things that we have online, because a lot of our patients do their own research, but patients with these conditions don't tolerate medications the same way as usual patients do. They're usually much more sensitive. And a lot of medications that we would use normally 3 times a day, we don't use during the day at all because patients don't tolerate them. So we only use them at bedtime. So all of the medications that we use in this patient population, we have medication handouts for the patients and for the physicians on our website as well.
That's brilliant, an excellent resource, really. And I have visited the website. It is very good. So I'm going to move on now. In a 2023 Centre for Diseases and Control Prevention, that is a CDC report, over 1.3% of Americans suffer from MECFS, equal to about 4.3 million people, costing the US economy $17 to $24 billion in lost income and medical bills. Worldwide, pre-pandemic, as many as 17 to 24 million people were estimated to have MECFS. I suspect these figures have doubled since the onset of the SARS-CoV-2 pandemic.
Yep.
Less than 1/3 of US medical schools have MECFS on their curriculum, and I would estimate that a similar proportion of international medical schools are in the same position. It was not on my medical school curriculum, for example. In your opinion, with this amount of suffering and economic cost, why has the medical profession ignored this debilitating disease?
I think a big part of it is because it's invisible. The Canadian government did a census in 2017, and that report's available online. But the Canadian government estimates that just over 5% of the population fulfills criteria for chronic fatigue syndrome, fibromyalgia, and multiple chemical sensitivities.
Wow.
So that's 1 in 20.
Wow.
And I used to do an exercise with my students, and somebody was smart enough, they actually turned it into a paper. I should have thought of it myself. But what I used to do with students is I used to say at the beginning, let's do a free association exercise. Tell me what comes to mind when I say chronic fatigue, fibromyalgia, and invariably they would say psychiatric, psychological, not real, frustrating to take care of, and there's nothing you can do for them. So when I have students come and work with me, I have 4 goals. I don't care if they remember the medications, they can always look that up. What I want them to know is it's real, it's not psychiatric, it's extremely rewarding to take care of, and there's lots that you can do. So those are the 4 big misconceptions. And that's why many of us were really surprised with long COVID, seeing these articles. What is this long COVID? And what's happening to these patients? We've known about this for decades. This is just simply post-viral syndromes. And we've seen these post-viral syndromes. Physicians love to give new names. There's something called post-chikungunya syndrome and post-Ebola virus syndrome and post-Lyme. And what do they present with? Fatigue, pain, sleep disturbance, brain fog, and unexplained symptoms. And so these are just post-viral or post-infectious conditions. There's a big study done I always want to make sure I pronounce it right, Dubbo in Australia, where an infectious disease clinic prospectively looked at the infections that came to their clinic. And invariably, regardless of the infection, 10% of people went on to fulfill criteria for chronic fatigue syndrome at 6 months, regardless of the infection. And so what they're saying is that this is not the infection, it's the host response to the infection that leads to these conditions. And that's why many of us knew that it would be around 10% of patients who would develop a post-viral syndrome after COVID. And those numbers keep coming back over and over again, around 10% of patients who have COVID. And in terms of the cost to society, when Canadian census did their estimate, less than 45% of those patients who are afflicted with these conditions who filled out the census were working. So it has a huge economic impact, both at the personal and at the societal level. So you would think if it's real, and if it affects a huge number of patients, and if it has a huge impact on the population. So you're probably familiar with the term DALY, D-A-L-Y, daily adjusted life years. So it's a way of comparing diseases in terms of their impact on society. And MS, chronic fatigue syndrome, and AIDS have almost an identical DALY. However, the amount of money that was spent, and if you look at like what the average is based on a DALY, MS gets the right amount of money, $100 million. AIDS gets more than its share at 5 billion with a B, and ME got less than its share at 5 million. So this is prior 2015, this is 2013 data. So 3 diseases with the same impact on society. One gets 5 million, one gets 100 million, and one gets 5 billion with a B.
This is like a massive criminal miss in medicine. And I must say, I would have fallen into the group pre-pandemic of your students. When you mentioned the term MECFS, I was ignorant. I knew people were suffering in real, and I never gaslit them. But the back of my mind, I thought, I don't know how to manage this. There's probably a psychological element. So I fell into that prejudice. Do you think it's because the majority of sufferers are women, and we're historically discriminated against in medicine? Do you think that's why it's been so neglected?
I think that's a big part of it. In fact, you mentioned the Complex Chronic Diseases Program, which was the first clinic for MEFM in the country that I helped set up. One of my patients told me that her family doctor told her that the reason they set up that clinic at Women's is because this is a crazy women's disease.
God.
And so this is not like from the past. This is like what we hear today. And even you may have seen this article that just came out in the last week. The NIH is trying to deal with medical gaslighting. And so there have a lot of doctors, including the Prime Minister of UK, have gone public to say these are just crazy people. This does not exist.
Gosh. Yeah, it's one of the reasons why we have this whole project, really, to educate people and enlighten them, but it's just so infuriating.
Maybe I can take the lead for a little bit, because one of the messages that I want to get across is understanding the language around long COVID, post-COVID, and chronic fatigue syndrome. Because most physicians, most organizations, most governments don't distinguish between long COVID and post-COVID. And whenever we had clinics in this province, we had post-COVID clinics, not long COVID clinics. And post-COVID clinic is for anything that happens after COVID, which includes blood clots, lung scarring, cardiomyopathy, et cetera, et cetera. And so most of the focus was going on those conditions. In fact, the reason that I was invited to participate in the ECHO for New Mexico is that they had a post-COVID clinic and were unaware of the fact that there was a post-viral syndrome. So they were taking care of patients, but they were excluding the patients who had no evidence of tissue damage. And so whenever you're looking at post-COVID, the Mayo Clinic, I think, has done the best job at suggesting a naming convention. Not accepted yet, and it doesn't matter whether or not you accept the naming convention, it's the concepts that matter. That post-COVID has three categories. The first category is the people who have tissue damage. So blood clots, hypercholesterolemia, new diabetes, new hypertension, cardiomyopathy, et cetera, et cetera. The second group are patients who develop psychiatric symptoms after COVID, so depression, anxiety, PTSD. And the third group of patients are those who develop, guess what? Pain, fatigue, sleep disturbance, brain fog, and unexplained symptoms with no evidence of tissue damage.
Mm.
That last group is what I'm calling long COVID. That last group is what the Mayo Clinic calls long COVID. I'll maybe just share my screen for a second and show you a couple of slides from some of my presentations. Because one of the things I often get asked is long COVID the same as chronic fatigue syndrome? And the answer is no, but partially. And so the first problem has to do with the fact that whenever you're talking about a syndrome, you're either in or you're out. So you either fulfill criteria or you do not. And remember that when we create syndromes as a medical community, it's for research to help us identify a homogeneous population to do research on. The reality is that that syndrome exists along a spectrum. And so a lot of people who don't fulfill the criteria are still along the spectrum. So in terms of the post-viral syndrome, most physicians are familiar with young adults who've had mononucleosis and who go out of commission for 6 months to a year. Some of them may develop and fulfill criteria for chronic fatigue syndrome. The vast majority don't, and they bounce back. And so that would be an example of a post-viral syndrome that's along the spectrum, but it's milder. And the milder the spectrum that you're on, the more likely you are to have a remission. And so with these conditions, yes, post-viral syndrome, some patients with long COVID will fulfill criteria for MECFS, but remember, there'll be a whole bunch who have a milder version who don't fulfill criteria, who are more like the post-mono young adults. But also remember that MECFS is not the only post-viral syndrome that we see. The post-viral syndrome can include fibromyalgia. And again, I talked about how physicians like to give new names. I love reading these articles because there's an article that came out and it said, hey, did you realize that 30% of patients who have long COVID fulfill criteria for fibromyalgia? Wow, we should give this a new name. We should call it fibro-COVID. The answer is no, we shouldn't do that because we've known forever that fibromyalgia is a post-viral syndrome. This is nothing new. And so POTS is another common one. And for some reason, POTS is particularly common after COVID. So that's the postural orthostatic tachycardia, but there's others. There's mast cell activation syndrome. Some patients will have IBS for the first time or migraines for the first time, or patients who already have pre-existing chronic fatigue, fibromyalgia, POTS, or these, if they get COVID, my patient said, well, do I now have long COVID and ME? Well, okay, yeah, but really what you have is your ME has been exacerbated by another viral infection. And so if we remember that ME, there's the post-viral, which is part of the post-infectious, but I also mentioned that ME can be psychological stressor or physical stressor. And so, yes, there is an overlap between long COVID and chronic fatigue syndrome, but it's that post-viral or post-COVID chronic fatigue syndrome is simply the post-viral version. But there's a lot of other causes for chronic fatigue syndrome, and there's a lot of other post-viral syndromes, either milder or other families that can co-occur. And so it becomes really confusing when nobody has a common language and people are still fighting. Is it ME the same as long COVID? Well, the answer is no, because some patients are going to have a milder version and some patients are not going to get ME at all. They're going to get FM or POTS or MCAS. And so I was surprised when we had a whole new name because my colleagues and I predicted this. 10% of people are going to have a post-viral syndrome. And why do we need to have post-COVID for, we have lots of viruses that cause lung disease or heart disease or myocarditis, but why did we have to give this one a new name? Because physicians don't have a problem treating the patients who have lung scarring or blood clots because they know what to do with them. It's the patients who have no physical findings and no laboratory abnormalities that are difficult, but also that represents the biggest part in terms of morbidity and cost to society and the individual.
You've given some clarity here, but it is really confusing when you're looking through the research papers because there is no agreed definition. There's lots of contradictory evidence because there isn't an agreed definition as to what's going on.
Well, when I do my presentation to physicians, I actually take them to Medline. And so most physicians are familiar with doing Medline searches. And so we know that if we type in atherosclerotic heart disease, that it'll map to coronary artery disease. We have a mapping system, and those are called mesh subheadings. So if I type in long COVID in Medline, it actually maps to post-COVID, so that the medical literature and the way that it organizes articles does not make a distinction between long COVID and post-COVID. And that's why my patients often come to me and they'll say, oh my God, do I have brain blood clots? And if you read the paper, it'll say, that these patients were post-COVID / long COVID. So in reality, we have no clue, but the more likely thing is that these are patients who had post-COVID with tissue damage, but the reality is we really don't know. And we're not going to know until the medical community decides on separating out the various categories, because it's just super confusing to governments, it's confusing to patients, and it's confusing to physicians. And that's why I teach my patients, when you read about this, is try and determine whether they're talking about post-COVID patients with tissue damage or long COVID patients without tissue damage who have pain, fatigue, sleep disturbance, brain fog, and unexplained symptoms.
So the last question I'm going to ask you, what do you believe is required in our existing healthcare system to enable effective management of MECFS?
I think that we need to mobilize the troops. Right now, in this province, although the government says we do have long post-COVID clinics, we don't, because you cannot see a physician in them. That apart from seeing me and Dr. McKay at my clinic or being referred to the complex chronic diseases program, which takes 3 years, that's the only access to care that patients with long COVID have right now. And so the problem is we can't expect a small group of a handful of individuals to take care of all the thousands of patients in the province. Right now, we have 2,500 active patients, and we have 600 patients on our wait list. And I suspect that a year from now, we'll have 3,500 patients on our active list. And so we're having to come up with really creative ways to service the population. So we're doing things like group medication visits. So rather than seeing patients one-on-one, I'll see as many as 60 patients at the same time to start them on low-dose naltrexone. And so we need to have a concerted, coordinated effort acknowledging that this is real and have a plan. Right now, there's no plan. Like, the government doesn't even think that there's a problem with long COVID because they have these post-COVID clinics that have physiotherapists and occupational therapists helping patients.
Okay. From my understanding, all the long COVID clinics were closed in BC last year.
But if you watch the Minister of Health and you talk to the person who was in charge of those things, they're not closed because there's still OTs and PTs that are running these clinics. And so they're closed from a perspective of physicians. Just a couple of months ago, the Minister of Health went on the news to say that we had more than adequate access to care for our post-COVID patients because these clinics were still open, not addressing the issue that there's no physicians and that most patients can't get any medical care except for advice on how to pace from these clinics. So until our government recognizes that there's a problem and that physicians as a group coordinate how we're going to take care of these patients, it's going to end up being people like me who are doing it on trying to help the CCDP clinic, but no coordinated effort for the province.
Yeah, it's such a shame. And I think that's the international situation too. So the hope is that the work you're doing and working with us here today, we can sound the bell really and educate physicians and get the medical profession moving. I want to thank you, Professor Arseneau, for today's interview and all that you do for the people in BC, Canada, the world who are struggling with complex chronic disease.
Thank you very much for having me. Pleasure.
Please join us for next week's episode of Long COVID The Answers. Some questions for viewers and listeners to consider. What are your top 5 takeaways from this episode? How will this episode change your practice or perception of this disease? What will you do to act on what you've learned? Please discuss your thoughts on our social media outlets, Twitter or X, the website blog, Instagram, Facebook, and LinkedIn. Please rate this episode